So I'd just like to talk to you about a study that I'm involved in based on the Haitian National Early Infant Diagnosis of HIV cohort. And it's to look at the risk factors of HIV drug resistance in Haitian children. So I'm not sure if everybody's familiar with early infant diagnosis. So it's basically the definitive diagnosis of HIV status. It's through the detection of viral DNA in the blood of the patient. So in adults, we mostly use antibody testing, which is an ELISA-based model, and it's effective only after 18 months of age in children, really, because of transplacental transfer. So of a positive mother who gives birth to a child, there'll be HIV antibodies in the blood of the child. So it doesn't really give an accurate diagnosis until about 18 months of age. So HIV DNA PCR allows accurate diagnosis at around 4 weeks of age. We do this with a dry blood spot collection because it's simple and allows us to do a central specimen collection, central specimen testing. And why is EID important? The mortality rate of untreated HIV infection in infants is very high, at around 20 to 30% within the first 18 months. So early treatment, we know after a study performed in South Africa, dramatically reduces early infant mortality. So EID leads to early initiation of ARV treatment, which dramatically reduces mortality. And there are also benefits for the mother to know that her child is HIV positive. So the EID program started in 2009, and it's a partnership between the Haitian Ministry of Health, PEPFAR USAID, the National Laboratory, and a reference children's hospital called New Petit Frere Sir, Partners in Health, and an IMIS GESCO, which is a local HIV organization, and the Caris Foundation. And I'm the director of the Caris Foundation in Haiti. The pilot started with just 9 sites, and my team is responsible for the technical support, the training, logistics, and expansion of the national program. This is a little bit of how we work in Haiti. Our teams are composed of clinical specialists, nurses with a lot of experience in HIV, and also public health specialists. And they're mobile teams, and they're based in the north of the country, the capital, the south, basically everywhere throughout the country. We visit each of the hospitals enrolled every week to every 2 weeks, and we do training, we test the children there, teach the staff how to do the testing, and we're responsible for the transport of specimens and the delivery of the results. We take the specimens by plane, boat, and road vehicle to the 2 reference laboratories in Port-au-Prince, and then we're responsible for the results to come back. And we have an automated online system that emails the results the same day that they're available, which we follow up with a phone call and also provide the hard copy of the results to the site level. And we're able to build on this model of regular visits to track all HIV positive infants identified by the program, but also outside of the program now. We're able to help track HIV positive pregnant women along their pregnancy, just to ensure that they are able to complete all the steps for prevention to mother-to-child transmission steps. We monitor ARV levels and essential antibiotics at the sites, and when there are stockouts, we're able to communicate with the central distribution networks and make sure that the drugs are available. We provide HIV technical support for children. We have clubs for adolescents living with HIV to help with adherence and also education. We're also able to distribute bed nets and safe water products to the families directly. So I started as a DPhil student in 2010, and the state of the program then was about, we had 25 sites throughout the country. This is Haiti. And then in 2011, we grew to about 40 sites. So that's giving everybody a headache. In 2012, we got up to about 60 sites. And now in 2013, we got up to about 74 sites. We're up to 112 sites throughout the country. That covers most of the population in Haiti, including some of these difficult to access islands here. And the yellow spots are where our offices are based. So we try to provide a kind of geographic coverage of the country. This is just one of our training videos that we do. We take the projectors and go and train the staff on how to perform the dry blood spots, how to correctly fill in the paperwork and the specimens to ensure that they're testable. Obviously, the one on the left is not acceptable, and the one on the right is. So these are I'm going to present to you the results of the national program for its duration, and it involves all of the sites apart from just 2 hospitals. The first is that it excludes is St. Damian's Children's Hospital, and that's a reference hospital. So generally, very sick children come there and are tested as a part of a diagnostic exercise rather than a kind of traditionally through the prevention to mother-to-child route. And also Jeskia, which is just a main hospital in Port-au-Prince that just refuses to share any information with the rest of the program. This is the first time this data will be shared outside of Haiti. It's only just been compiled, and so it's great to share that with you. So untreated mother-to-child transmission globally is around 15 to 45%. In the program, in 2009, it was a small study showed that it was around 27% of mothers enrolled in one site in Port-au-Prince. And currently in South Africa, which is really the gold standard that we're aiming for, is around 2.7% nationally. So just looking at the number of tests that we've performed in 2010, 11, and 12, really looking at the first PCRs here, we've grown up from about 1,500 to almost 3,000 tests, first PCR tests. And we estimate there are around 6,000 HIV-positive pregnant women who deliver in Haiti every year. So we still have somewhere to go. The second line here is an estimation of our program plus the 2 hospitals that are excluded in the rest of the data. So we're around almost 4,000 children that are tested every year. This is looking at second PCR tests, and the second PCRs are performed on children whose first PCR is negative. And those children mostly go on to be breastfed, so still have a risk of exposure of HIV through the breast milk. So we aim to test children again 6 weeks after they've finished breastfeeding. And you can imagine it's very difficult to hold on to those children who are negative all the way through about 18 months of age. So we're only up to about 450 children that we manage to find each year for a second PCR. But of those children, the rate of transmission is very low. It's obviously a skewed data because many of the children who become positive through breast milk transmission will probably have died or be ill or not, or just not tested by us. So this is probably the most interesting slide, really, is looking at the overall transmission rate for the country. In 2010, when we started with just a handful of hospitals, the rate was around 7.4% transmission. And as we expanded the program in 2011 and 2012, doubling and tripling the number of sites, the rate rose to around 8.5%. But in 2013, with our largest number of sites, up to 100 sites at the end of 2013, our rate has really decreased to around 6.8%. And that's a huge success of the program. And I think mostly can be attributed to the country's decision to adopt option B+, which is the provision of antiretroviral drugs to all HIV-positive pregnant women at any stage throughout pregnancy, and then to continue that for life. And also, we'd like to think that's due to some of the impact of the work that we've been doing as well. And this statistic of 6.8% has just been accepted a couple of weeks ago by the Ministry of Health as the national statistic for transmission in Haiti, because the plan for Haiti is to eradicate mother-to-child transmission by 2015. So we needed a baseline statistic. Looking in a bit more detail on the program, we were able to show on this green line the proportion of women that receive any ARVs during pregnancy throughout the program. So in 2000, between 70 to 80% of women receive some form of antiretroviral treatment during pregnancy, which is an achievement. But we obviously have space to improve that. We're aiming for 100%. And for children, there's another intervention that is very, very effective to reduce the transmission of mother-to-child transmission of HIV, is to give children a course of antiretroviral treatment immediately after birth, aiming to start within 72 hours of birth. And throughout the program, again, we've had about up to 74% of all children who receive some form of prophylaxis after birth. And if you compare that to other countries around the world, this is a figure published by the WHO, looking at the blue line is the percentage of women, positive pregnant women, who receive some form of ARV intervention. And this is old data from 2007 to 2009, but it's around up to half of women. And for the green line is the percentage of infants who receive prophylaxis after birth. And it's at 2011, it's around 41%. So Haiti really compares pretty well to other lower and middle income countries. Now this is a very ugly graph, but I couldn't make it look any easier to read. So this is looking at the mother and children as a pair, as a paired group. So the blue line here looks at mothers and children who have received any form of intervention. So either the mother has received drugs during pregnancy, or the child has received prophylaxis after birth, or both the mother and child have received something. So again, this has risen through the program from a high level of 82% to about 93% of mother-child pairs receive some form of intervention nationally. And the lowest line here, the turquoise line, is actually the transmission rate of this group. So if the mother and child group receives any form of intervention, the rate has been extremely low, at about from 2010 at 5% to 2013 at around 3.5%. Again, which is a great thing for us to show in the program. And looking at this darker green line at the bottom here, this is the inverse. This is the mother-child pairs that receive no form of intervention whatsoever. And that has steadily decreased from around 16% in 2010 to 5.8% in 2013. But the transmission rate for those pairs where no intervention was received has steadily stayed at around 30%. So it's this group that we need to target to reduce transmission further. And just looking at the age of our first PCR, we have over half of our children tested before the age of 2 months. And this is supposed to give some kind of level of transmitted early transmission versus late transmission of the older children who may have received it through breast milk. And follow-up. So really our program, I think, is one of the few programs that links the testing to the follow-up of positive children, to children who have been identified. And we have up to almost 90% of surviving children have been placed on antiretroviral treatment from the beginning of the program. And all of these children are follow up through our team in a kind of a national system. The mortality rate is still extremely high, and we have around a 20% mortality rate every year of the program. But we're making efforts to reduce the number of children lost to follow up. So in 2009 to 2011, it had stayed at around 20% of lost to follow up. And in 2012, with improved community health workers and tracking, we've been able to cut that to about 10%. But from the very first year of the program in 2009 to 2010, 60% of those children who are identified are still alive and still on treatment. So looking at the priorities for our program nationally is really to have every single woman tested, pregnant woman tested at some point during pregnancy or even directly after birth. We have lots of problems with registration because women often give false addresses because they receive services at multiple hospitals. Our record is up to 12 hospitals one lady has received care from, because there are small incentives received at each site to access care. So this makes life difficult when we're tracking children and trying to look at transmission rates. And again, option B plus, women who are positive and pregnant should start on ARVs throughout pregnancy and throughout life. We have to encourage hospital delivery and to make sure that the women are tracked who miss their ARV appointments, and to test children who are born outside of the hospital. For infants, we want to ensure that every exposed infant receives prophylaxis within 72 hours. And often we found that the infant prophylaxis is locked up in a cupboard after 5 p.m. or at weekends. So just working with hospitals to ensure that these services are available 24 hours. And of course, if the child is positive, we really need to get them started on ARV as soon as possible. So why have we decided to think about HIV drug resistance in children on the back of the EID program? We've made some progress with EID, and there are some advances in prevention to mother-to-child transmission with option B+, and we're just built upon the established model that I've shown you today. And we need to know what the drug resistance rates are, because it helps us plan the service nationally. How much of a particular drug do we need to order and when? And right now, we don't have access to viral load monitoring, and the monitoring is largely clinical. And very little is known about patterns of resistance in Haiti at all, in the adult or children, pediatric population. So children are at high risk of developing drug resistance because they can be transmitted with resistant strains from the mother directly in utero or through breastfeeding. And they can also acquire minor resistant strains through the selection pressure during the postnatal prophylaxis. Because they're supposed to be, some of our infants can start treatment at 4 to 6 weeks of age and have to have lifelong treatment. So again, this increases their risk of developing resistance. So it's really the scale-up of PMTCT efforts in Haiti has likely resulted in the decrease in pediatric HIV infection, but an increase in the proportion of those children with resistance. And studies have shown that clinical monitoring is not accurate to develop virologic failure, and the dry blood spots have been shown to be a good medium for testing of resistant strain genotyping, and viral load in adults, but not really in children. So again, these are some of the reasons why we decided to attach this study to our EID program. So the research objectives of the study really are to look at patterns and prevalence of resistance in children in Haiti. So in 2 groups of children, looking at the newly diagnosed children who are less than 18 months of age, who've been diagnosed with the EID program, and also to look at children who've been on treatment on ARVs for between 12 and 36 months, and also to start a viral load service in Haiti, and to classify the proportion of patients who are failing first-line treatment, and to evaluate the risk factors of HIV drug resistance, both individually and systemically. So looking at factors such as clinic staffing and stockouts, and see how if we can find some correlations that will lead to improvements in the program nationally. So I've looked at the 2 subgroups. So for the newly diagnosed infants, we've just taken the last 200 positive children who are identified through their dried blood spots, and they're being sent to the CDC in Atlanta for HIV genotyping. Looking at children on ARTs between the last 1 to 3 years, we're going to collect plasma and dried blood spot samples from those children, between 600 to 700 children. We think that's basically all of the national cohort of children who have been on treatment for this period. Plasma will be tested for viral load at the National Laboratory in Port-au-Prince, and those children who have unsuppressed viral loads, defined as greater than 1,000 copies per mil of virus, the dried blood spot will be sent to for genotype testing. The WHO have released a set of early warning indicators, and these are indicators that countries have been asked to monitor because they feel that this will minimize HIV drug resistance developing in the population. Almost all of the work has been done in adults, and there have been no large-scale studies that relate the early warning indicators to individual patients developing resistance. So that's one aspect of the study that we'll be looking at. And we aim to do this within a multi-level analysis, so looking at clinic level factors on the level 2, and then factors that involve the individual mother and child pair. So to explain in a bit more detail, the clinic factors we'll be looking at are to see whether the prescribing practices have any correlation to the development of resistance, to see whether physicians really are prescribing the recommended appropriate first-line treatments. Looking at periods of stockouts of drugs at the sites and modification of the regimes, looking at to see whether a clinic is publicly or privately run, whether transport fees and other incentives are provided at the sites, and to see whether the service is led by a doctor, a pediatrician, or a nurse. Some of the individual factors that we'll be looking at are basic demographics such as socioeconomic status, distance to the health facility, and maternal ARV adherence, and maternal ARV history. And also looking at the percentage of patients who are lost to follow up and to see how the individual adherence will lead to drug resistance. Adherence is quite difficult to look at. In adults, we can count pills, but in children to take syrups and suspensions is a bit more tricky to look at. Again, looking at if the regimes are appropriate. So basically the hypothesis is that our clinic level factors are as significant as individual factors in the risk of development of HIV drug resistance. I think a lot of blame is placed on patients to say that resistance is caused by poor adherence, but if there are clinic level and systemic factors that prevent a patient from being truly adherent, then I think that's interesting for us on a kind of public health program level to know about, and also to look at whether the WHO early warning indicators actually do help predict individual drug resistance in children, to look at what are those most influential factors are. So the results that we hope to achieve really should give a proportion of children suppression on first-line treatment. It should give us a proportion of children with possible drug resistance, and give us the identification of the mutations observed, the most commonly mutations observed, and to give the drugs that those individual mutations will give resistance to, and to look at the relative importance between those clinic level factors, and individual factors. So the study has been very slow in moving forward. Most of the delay has been due to the difficulty in getting the IRB process. The first IRB approval was submitted 2 years ago to the CDC in February 2012, and we were given approval in February 2014. The Oxtrec and the Haitian national IRBs were really quick to get approved after that initial CDC issue. And our funding really just arrived in March 2014 for the study. So we're really in a position just to get started right now. Right now we've sent off the retrospective samples already, and now we're looking at the prospective sampling for children. And just determining the number of HIV positive children in Haiti is, again, been a huge challenge. There's no very good medical records. All of the different hospitals and big organizations use different medical record systems, so it's been a challenge to find out how many children actually exist and are eligible. But right now we have a formal list of children who are on treatment and are positive, and again, we're sharing that with the Ministry of Health. So the sites have been selected for the participation, and we hope to start, or we will start the specimen collection in May, June and July. And that's really, I'd like to say thanks to my supervisor here in Oxford, Professor Sarah Rowland-Jones, Andrew Pollard, and Adrian Smith, and USAID, PEPFAR, and the Ministry of Health who helped with that process. Thank you very much.